Dearest Dr. Schulman, friends and colleagues, I would like to thank you all for giving me the chance to say a few words for this distinguished audience at the Global Oncology Symposium. As we all know, prior to September 2011, non-communicable diseases, NCDs, including cancer, were not acknowledged. NCDs had no mention, no name, let alone an acronym at the global health corridors where action and money meet. We, the people on the ground, knew about the burden of cancer in our countries. Those in developed countries called it by its proper name, cancer, whilst we in developing countries called it that disease, God forbid. Why? Because we never saw the patient again who had that disease. You, the doctors, also knew about the horrors of having to face cancer in the developing world, but the global health community was intent on making a geographic dichotomy between diseases. The rich countries facing NCDs, whilst the poor countries facing infectious diseases. Wishful thinking at best. As president of the Union for International Cancer Control, UICC, I was proud of the role UICC played in moving the needle in global cancer advocacy, putting NCDs, including cancer, front and center in the political corridors where it mattered. That advocacy work was extremely important. Not only has it legitimized what we already knew, it finally acknowledged the 18.1 million souls afflicted with cancer annually. More importantly, it set in motion a global action plan, monitoring and evaluation plan, proven WHO best buys, proven investment case for investing in prevention and early detection, and many more. The hope was that governments cannot play ostrich anymore. They were given the tools and recommendations and therefore would be obliged to take on their responsibility with regards to NCDs and cancer and report back. However, since then, we still talk about 9.6 million deaths per year, predominantly in developing countries. Of course, we cannot say that improvements have not taken place. More and more countries making cancer control plans and establishing cancer registries and implementing the WHO best buys by tackling tobacco, salt and sugar, etc. However, the progress is too slow for it to make a dent in the mortal statistics of almost 7 million people dying prematurely each year, predominantly in the developing world. New collective thinking became imperative as to how we can shift this deadening narrative on the ground. Global advocacy did what it could, but is it fair to expect developing countries to be able to fast-track 70-year-plus lag in dealing with cancer? Low-income countries who are barely able to deal with ongoing infectious diseases have no infrastructure for cancer to be able to do it all alone. I know that we're not supposed to talk or invoke a global type fund for cancer, as it is said that it will not have any sort of traction, like it did for AIDS. But having witnessed firsthand the dismal and tragic situation of cancer care in many developing countries, it is very clear that sub-countries, especially those that are starting from scratch to build the infrastructure for cancer, absolutely need a leg up. And this is what UICC and you as partners in health and few other bold initiatives decided to do. We all understood that we cannot ethically keep on pontificating from a distance. We needed to walk the walk of those countries who literally have to start from ground zero. More importantly, we also understood how global donor systems are keeping us all locked into the usual mode of operation. We all decided to disrupt the status quo. The models of both City Cancer Challenge Foundation, CCAN, and Partners in Health, PIH, and other such bold initiatives have challenged the way things have been done. And I am a total believer of those models. CCAN initiative was established in 2016, then incubated and then formed as a stand-alone foundation by UICC. As to PIH, most of you here are either part and parcel of PIH or at least know about its work. Naturally, I have heard about all the great work of Partners in Health. However, seeing is believing, my friends. My latest visit to Rwanda made me a strong believer. After driving 3 hours across the beautiful hills and winding muddy roads from Kigali to Butaro, suddenly in the middle of nowhere loomed a big campus. Even though we knew where we were heading, it just seemed nearly impossible to have Butaro Hospital and the University of Global Health Equity, UGHE, situated in this out-of-nowhere place. Upon touring this wonderful hospital and university, seeing the throngs of patients waiting patiently for their turn to be seen, and looking at the Rwandan health professionals working alongside the best of doctors and nurses from all over the world, conjured up President Obama's quote of the audacity of hope. Here in Butaro, hope stood tall. Hope was also physical, cemented brick by brick, boldly and audaciously, defying all those naysayers who say it cannot be done. Of course, there is still a lot to be done, but the proper foundation is built and many gaps have been ticked from the long to-do list. Here in Butaro, lives are being saved one at a time. What is it about PIH model and that of City Cancer Challenge and other similar initiatives that are making things work? My top 10 reasons. Firstly, these models are bold and invested in making a difference on the ground, both either choosing cities or communities or even countries to work hand in hand with. Secondly, both have an absolute long-term commitment to the work. They are not models or organizations that will do fly-by work. There is a real understanding that delivering cancer control requires long-term commitment and tenacity. Those models are truly invested in making a palpable impact. Thirdly, those two models believe that working side by side with the local community is the only way forward. Local communities have to be active partners and not just passive recipients of support. Fourthly, those models understand that high-level political will and engagement is key. Therefore, they utilize their global credibility and power to make sure that there is a top-level executive infrastructure on the ground that includes all stakeholders influencing cancer control in that country or city, be it the leader, the mayor, the NGOs, the healthcare providers, the private sector, and the patients. Thus, the work can continue long after these organizations are gone. Fifthly, the belief that all must work on one comprehensive strategy and plan for that country or city. Many a time we have all seen countries working with multiple global organizations in a haphazard way, causing inefficiency and duplication of resources and efforts. Sixth, those models understand that many health ministries, especially in developed countries, do not all have skilled strategic planners on their roster of staff. For example, the CCAN team performs the facilitator role on the city executive team, supporting the group in strategizing, planning, and prioritizing their needs, eventually leading to a well-thought-out, comprehensive, costed action plan. Seventh, those models do not just believe in collaboration. Those models are designed for collaboration, walking the talk of public-private partnerships. CCAN and PIH are not just models that want to tick the global health box. They own the box and they define it and fill it. Many of you here in this room have heeded the call for collaboration, and I thank you all for that. Eighth reason, those models invite all partners at the right time and on the one comprehensive plan that the city or the country approved and defined. Ninth, those models understand the importance of public-private partnerships. You have changed the paradigm of how the private sector can be engaged more effectively. 10th, BIH and CCAN, like models, absolutely believe that it is in the doing that lives are now saved. Yes, it is in the doing that lives are saved. I know that there are many cancer centers and institutions all over the world are doing important global work as well. I urge you all to join, collaborate, and coalesce with each other's work where possible. We may not get a so-called global type fund for cancer, similar to what was given to fight AIDS. However, collectively, I strongly believe in my heart of hearts that if we continue along this new paradigm shift on how we deliver support to global cancer control, we can disrupt the status quo and force a change in the way the global donor system works. I want to thank you all wholeheartedly, individually and collectively, from the bottom of my heart, for paving the way to this new way of doing things and of delivering impact. Thanks to you all, we now have proven models of how impact is achieved when all hands are on deck. Most of all, thank you for rolling up your sleeves and just doing the work that needs to be done. You have collectively transformed mere empathy into solid hope and of lives saved. Thank you all again, and good luck in your discussions today.